This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Welcome everyone to this afternoon's paediatric nursing session. We've got two fantastic speakers for you this afternoon. The first of whom probably know that doesn't need any introduction for those of you that were at this morning's plenary session, Dr. Martha Curley, who's the Alan and Robert Capito Professor in Nursing Science from the University of Pennsylvania, and this afternoon she's going to speak to us about leading change, science supporting the future of paediatric nursing practice.
Okay, so this is a kind of interesting talk that, again, kind of brewed in my mentality for a while. So I've been practicing for a long time. I started practicing in the 70s, and this is a photo of at the time, a pediatric intensive care unit that I was working in. And how many of you kind of remember that era? Not too many people. Oh my God, I'm that old. But it was a wild time because we didn't really have too many of the monitors that we have now. I mean, I remember when we got SAT monitors in. Believe that. When we put a SAT monitor on a kid, it was like, oh, is that what they've been doing all this time? That blanching out effect. But anyway, I had to essentially learn peds critical care by looking at what was going on, really primarily in the adult critical care area, and I tried to think about what that would be like for my kids that I was taking care of. But now it's really like Technicolor. There's a big market now on pediatric machineries. Parents are there all the time. I mean, they really weren't there all the time in the 70s, and they're there all the time now. And we'll talk about that after Liz talks and I come back and talk about families. But it's a whole new world. And I do think that when I was a clinical nurse specialist in the medical surgical intensive care unit at Children's in Boston, it was a hard place to work in. And Donna Deers was a mentor of mine. And Donna Deers used to be the editor of the journal, I think it's now called Sigma Theta Tau Journal. But she was really my first role model who really taught me to be almost a feminist for nursing. You had to really understand the practice of nursing in order to really carve out a place for the practice of nursing. And this was a beautiful quote that I cut out and I put underneath my blotter at Children's. And this is really how I worked a lot of the days, like near tears, trying to figure out what was going on. But it's believe in nursing in the wildest possible expanse of role and function, and believe so strongly that your beliefs can sustain you through the battles with the unknowing, unthinking, deluded, and the barefoot pragmaticists who wish to restrain the ideas and the talents of nurses. And we have we never practice anything but nursing, but a lot of people feel as though they can practice nursing without a license. So we really have to carve out what we do and what we do well. And in order to do that, we have to build the science to support, some level of autonomy as we go forward. So this was really one of my ideas. My first idea as a new graduate without the SAT monitors. I worked at Bay State Medical Center in pediatrics. The shirt that I'm wearing, that yellow shirt, I sewed myself. I was really like a little mom and, worked weekends and whatever. But then I became passionate about nursing and did a master's degree, was a clinical nurse specialist for a long time in this tough place to work, and then now I consider myself a clinical trialist. But throughout that entire time, I really, maintained my belief in nursing, in the profession of nursing. And the core to me about what we do is that we formulate caring relationships with patients and their families, especially in pediatrics, that facilitate healing. And I talked a little bit about that earlier, but it's through the relationships that we have with people that we figure out what they're all about. And we form relationships with those individuals. And then we figure out what we need to do to have them heal. And as you know, you can heal, but you can die at the same time. So it's a process of what's important for that patient and family and how you move them forward. The stuff that I do has to do with three major things. I do interventional studies. A lot of the work that I've done has been on parent need and priorities in critical care. I've built a lot of instruments because in order for us to really study what we do, we need some instruments to say whether or not, if we are saying that we want to avoid an agitated state, we have to be able to describe the sedation agitation spectrum. So, I end up building a lot of tools because we needed the tools in order to do the interventional work, the multi-site clinical trials of nurse-led therapies, to really support knowledge development in the field. So over time, and it's kind of interesting, is that I never, when I had that yellow shirt on that I sewed, I was a staff nurse. I wanted to be a staff nurse. I loved being a staff nurse. And then you kind of just evolve over time. And I would never have said that I would have had a PhD in nursing, but I did only because I wanted to do science. And in order to do science and to do funded science, at least in the States, you have to have a PhD, or else you won't be able to get the monies that you need. Collectively, I think as a nurse, we have an obligation to the field. We all have to find a little bit of what Ruth talked about. We have to sustain our enchantment with the practice of nursing. And the enchantment is not a word that I made up. It was a word that Patricia Benner once talked about how we all enter nursing because we love a certain piece of nursing. And to maintain that love of the profession, the things that we do in the profession requires us to sustain ourselves and to find the energy that we need to sustain our enchantment. I still love going in and interacting with families and interacting with really sick kids over time. And that's never going to go away, but that's kind of what I love to do. We all have an obligation to support new talent in the field. We can't be 70 years old running around a intensive care unit. We have to, there are people after us that we are morally obligated to support their growth so that they can continue to develop the profession. And then we have to be able to, when we work with people who are new to our field, really catapult their development. And so what is it that we can do to stimulate their personal development? And, not only managers do that. You have, as a staff nurse, an obligation to work with your other colleagues to support this, mutual respect and obligation so that the entire field moves forward. And I think in order to do that, we have to think differently a lot about the practice of nursing. And so I think it's about this revolutionary thinking of what we're able to do. And that includes, as nurse scientists, a clear sense of what nurses do. I think we also have to strengthen the science so that nurses can own their practice independently so that they can own the nurse-led therapies that I think they can manage. We have to design systems to better support that autonomous practice. And then whatever we do, however we do, every single change in the profession has to be measured so that you can say, when we did this, this was the outcomes. When we did, Y, this was the outcomes as well. So we have to be able to measure any impact. And when I'm in Boston and I go to the leadership meetings, it's, when I go there, every single change that they talk about, I'll say, that's wonderful, it's really good, but how are you going to know that you made a difference? And what are the things that you're going to be measuring? Half the time they run for the room because it's like, oh, Martha's going to make us measure all this stuff, and like, oh my God. But it's not hard to do. You just have to partner with people who know how to do the measurement, and then you, because you are nurses and you know what you're measuring, you just have to lead the way. Okay, so you partner with people. You don't have the expertise in measurement, but you just have to know who you can partner with. And I think the way that we've trained nurses to be nurse scientists, we've trained them to have to ask the questions, answer the questions, run all the stats, write the papers independently, which is not how you do science. You know, it's about a team effort in doing it, and you own a piece of it, and you collaborate with others. So what I want to talk about is several converging phenomena that really are going to push us forward to stimulate new programs of research, talk about some data that supports positive impact of nurse therapies, and then think about how we could really re-envision this future of how data will support nurses functioning to the highest level that they feel possible. Before I start, I just want to see a show of hands. How many of you think that you are functioning to the fullest potential of your knowledge and expertise independently? Look around. No one's raising their hand. But it's really, that's sad, isn't that? It's like kind of, you know, what are we doing here? It's like we have to stop doing this. So converging phenomena, you know, what is it that, what's this new world that we're living in? The new world has a few things. First, the Institute of Medicine's report on the future of nursing said that nurses should be functioning to the fullest extent of their education and training, and that we have to promote higher levels of knowledge, that we're full partners, and that we're part of this you know, we have to be part of the solution in redesigning care, which is really cool because in the States, at least the Institute of Medicine is like nirvana on who talks about what, and nurses themselves are getting impaneled on more of the major committees that are driving healthcare in the United States. And this is kind of like a new thing. That you can't put any group together anymore in the United States without a couple nurses sitting on the panel, which was unheard of in the past. The second thing is Patricia Benner's work around educating nursing, and what she more or less says within how nurses are trained, that we have to get to a BSN as entry level, that, you know, we can expect 10 years after, you know, you finish your baccalaureate degree, you should be moving towards a master's degree, that, you know, we need to be able to think about coursework that really matches what nurses do. Sometimes, how many of you are responsible for training nurses? Work in academia. It's really, sometimes the coursework is like out of control. It's like we're teaching things that really aren't important. We keep putting stuff into the curriculum. We never take anything out. And then before we know it, it's like, well, what the hell are we training here for people who can't even graduate and take care of patients anymore? So, you know, just recently at Penn, we bombed out the entire curriculum. We redesigned the entire curriculum and really rethought a lot of what we were training. And, you know, yes, we're training people on statistics and research methods, but we also added a course senior year that they have to participate in research, in meaningful research that's related to patient care. So we're putting things into the curriculum, but then asking them to really work, you know, through the problems and design quality improvement initiatives and measurement strategies, because nurse leaders now have to do that. You take care of patients, but you have to be able to measure the extent to which you're making a difference. And so all nurses fundamentally have to have that level of expertise. How many of you have seen this slide of programs of research? This is a slide that finally helped me understand what it was about building a program of research. It comes from the Canadian Clinical Trials Network. John Marshall published it over almost 10 years ago. And it talks about how when you have a research question, you have to design a study matching what is known, you know, in the field. And really you articulate what you're interested in, but you have to understand what's currently known, what is currently practiced, and then you have to know about the prevalence and the risk factors. You really have to nail down the operational definitions, and as far as interventional trials are concerned, you run a pilot trial and then a larger trial, and then you move your data out there. So everything along this can be done just to gear you up to do a definitive study on a phenomena. So specifically, for example, when I was doing prone positioning research, I really had to figure out what was known. So I did a systematic review, and then I did a survey of how many people were really doing prone positioning, and then tried to figure out how to design a protocol, had to nail the definitions, and then trialed it out, and then did a definitive trial. So you can't go to a definitive trial till you've done all the other steps. But sometimes we forget about that as we are doing that. But programs of research, meaning that you're sticking with a topic until you answer the question. Some people do research only because they have to do research. They have to do a project to get out of grad school or something. But really, when you're growing a program of research, it's really 3 or 4 publications on a topic within the field. So it's defined from that. As far as like what is the nature of nursing science, I've had people say to me, so you have a PhD in what? And I'll say, in nursing. And they'll say, I didn't know you can get a PhD in nursing. And then I'm like, well, what do you mean? You know, it's like nursing has a science just like everybody else has a science. And when you have a PhD, it means that you have been groomed and you know the knowledge development in the field and you're contributing knowledge to the field. And this is what we study. We study about relationships that facilitate healing. We pay attention to the human response. We look at objective and subjective data. So qualitative research we love because that's all about, you know, the subjective experience, but also objective data. We want to know about how you diagnose and you treat things using clinical judgment and critical thinking. And we want to be able to at least get to safe, quality, and evidence-based practice. So we build knowledge in the field that really supports our clinical judgment and what things we're responsible for. Again, I showed this slide earlier. I love clinical wisdom and interventions in critical care. Those of you who are thinking about building a career as a scientist within the field should really think about pulling this work and just thinking about how they've separated out everything. And there are definitely good examples about how through the 9 dimensions people have built science. For example, diagnosing and managing life-sustaining physiological functions. Susie Burns' work on how to wean a patient from mechanical ventilation. How to manage a crisis. Pat Karakitis' dissertation was on how nurses make decisions titrating pressors at the bedside, and why do they titrate epi and not dopamine or not dobutamine or millerone, or how is that, you know, how does that play out? So how do you manage that? Providing comfort, Kathleen Puntillo's work around limiting the impact of painful procedures. So whole programs of research on pain and patients' response to pain. Nancy Moulter's work on caring for patients' families. She's the one that coined the term that families are not visitors. They're part of the patient's experience. And then we've talked about preventing hazards. I have a doctoral student who's looking at light and noise and positioning after cardiac surgery. The primary outcome variable is time to physiological stability. So post-op stage repair, how quickly can the nurse contain the environment to get the patient to be physiologically stable? And how do you really measure that? Because that's what nurses do. We're vigilant, you know, of the environment. Death and decision-making, Cinda Rushton's work on recognizing how to transition people from, you know, curative to palliative care. Making a case, Elaine Meyer's whole program of research on how to enhance communication in difficult scenarios. So she's contributing there. Mary Jo Grant's work on patient safety. And it's kind of interesting because if you're thinking about entering any of these different areas, you just have to know who's publishing in the area and see what they're doing, and seeing essentially the limitations of what they're doing, and then you want to go in there and plug the holes. And so it's okay to obviously to build on other people's work. And then Barbara Daly's work on transforming healthcare systems in a nurse-run MICU in the adult population. So we definitely need more programs of research in areas of things that nurses study. And this was just an example of some things. The problem with a lot of this is funding. Try to get these studies funded. And I've got exceptional and outstanding levels of funding because typically now at the National Institutes of Health in the United States, you can't get funding unless you write an exceptional application. And it has to be an application that addresses the question at the level that you need to be asking the question. And again, putting together research teams that would enhance your success. So really an application essentially has no weaknesses or negligible weaknesses. So end up as a researcher like this. It's like you have all these beautiful ideas and you think you're going to try to go for funding, but it's like, beating your head against a wall because you can't do it. But you don't have to get a lot of big money to do some of this stuff as long as you can string together small studies that will fund, pieces of what you're doing. For me, it's always been like a kid in a candy store. Because it's almost like I have attention deficit disorder. I can't ever just have one research project going on. I have several, and I have several streams of things that I'm doing because there's so many questions that we have. It always makes me nervous if someone comes up to me and says, I don't have a question. Can you give me a research question? And I'm like, oh my God, just go to the bedside and look around and start thinking about what you don't know when you're taking care of a patient, and that's where you get your research questions. So it's always been like a kid in a candy store, but I'll give you some sense of what I think. Given what the Institute of Medicine is saying, educating nurses is saying, where our science is, where I think would be 10 hot areas to go forward, at least in the next 5 to 10 years. So, and it takes, those of you who do this know that it takes 10 years to answer a question. And we have to do something very different quickly because knowledge development, we need it now, not in 10 years. So anyway, but what are the top priorities? You saw this slide. We need to think about day-night cycling, noise control. I mean, the smells in some of these units are like horrendous. Why can't we just do something with enhancing the smell? Family presence, we bring them in, but what do we do with these families? Is it always the positive? What is it? And then just how do we make the place a little bit more comfortable? And what's the benefit of doing that? We've looked at the second research priority, looking past the intensive care unit. What is it that nurses do in the intensive care unit that translate to after intensive care unit? Currently, I'm doing a study is on restore cognition. I'm looking at kids 3 years after critical illness to see what is it that they receive from sedatives and level of sedation on their cognitive outcomes. Because nurses manage that, and we need to do a better job with that. The third priority is getting to these fundamental activities. If we're going to own something, what is it that we can do? Can we get calories in faster? Will kids be more comfortable if we're managing a sedation? And then what can we do to avoid deconditioning? So that's number 3. And then managing some straightforward therapies. Boy, that's really screwed up. But also more complex therapies. And this is the half-pint clinical trial where we're looking at tight glycemic control and what's the impact of tight glycemic control on patient outcomes. The fourth research priority is to move towards targeted therapies. We can't keep enrolling everybody into all trials. In pediatrics, we have a problem with that because we don't have enough patients. But we need to really start looking at phenotypes. I have a doctoral student who's now classifying the difficult to sedate phenotype. What is it with Liz? Red hair. What is it with some of these characteristic features that patients have that we know, but we need to start, identifying that a little bit different. So getting to more targeted therapy is huge. We need to look at implementation science. How do we get things in and stuck? Rather people only doing things when it's been done for 10 years, okay? So how do we move therapies in? And most of it has to be about our accountability in leading change and not being afraid to be the leader and not being afraid of making mistakes. As a clinical trialist, you have people calling you up with adverse events. It's sometimes painstakingly hard, but you have to take a shot and you have to answer the question. The sixth is that we need better outcomes to better describe what we do. So anything that we can get to that can describe that a little bit better would be great. And we also need to use more mainstream outcomes like length of stay, functional status, things that typically haven't been associated with nursing, but I think, should be. Seventh priority is what I talked about earlier, is this reciprocal relationship we have, the extent to which continuity of nursing care really impacts patient outcomes. We need to measure around that. And eighth is to rethink our models of care delivery, rethink primary nursing, rethink a nurse is not a nurse is not a nurse. And we all have areas of expertise. So what happens if we have a nurse attending model where you have one nurse who is the attending or the consultant for a patient? What would that look like? And could we do that? And would the patient experience be better if we did? The ninth is to really elevate the floor of practice. For years, we've been regulating nursing to the lowest common denominator. We don't acknowledge people's evolving levels of expertise. So we have to start differentiating practice so that new nurses do a certain level of care and more expert nurses can have more responsibility and accountability to use their clinical judgment in the patient's best interest. And last but not least, we need to do a better job in team science. We can't keep being, you're the principal investigator, it's all of your stuff. It's about who within a team of questions is taking the lead at any particular time. Dr. Wolf said earlier, it's the cardiologist, the cardiac surgeon, and the intensivist, and I would argue that sometimes a nurse could be the lead, okay, especially in patients who have nursing problems. If they don't have nursing problems, okay, we'll let other people be the lead. But if there's a nursing problem, if they're in a hospital because of a nursing problem, they ought to have a nurse attending or a nurse consultant. But be able to share that. I worked in a place where everybody was at the top of their game, and it really was about working in nirvana. And I think once you experience everyone performing extremely well within their subspecialty, the psych, the social workers, the nurses, the physicians, everyone at the top of the game, it is nirvana. And when people don't do well, it's because someone might not be practicing at the top of their game. So we need to think about interprofessional research, which is not just, one question, one answer. Is about looking at a program, what are the nurse questions within this program, and then leading that charge forward. Again, it doesn't always have to be led by the people who have MDs after their name. It could be led by anyone whose question within that domain is important. To end, the vision of pediatric critical care nursing practice is one that is patient-centered, one where we can create this healing environment, one where we have differentiated practice based on levels of expertise, and one where the systems can support a high level of nursing practice. And again, I think nurse scientists who are building the science to support that practice need to really become leaders in the field, working collaboratively with their research partners to change how we currently do science. So thank you.